start with Dr. Ambika. Dr. Ambika is the director of the Neuro Ophthalmology Department of Shankar Netralaya, Chennai, and she would be presenting the first grand round case.
Thank you, madam, for this wonderful opportunity. And I'm going to get my fellow Dr. Aarti Rajkumar start the case presentation. And this was one of the challenging cases which we had faced recently. And I think few of the members who are present in this panel will be aware of this because we had a discussion briefly about it in one of our international neuro-ophthalmology group. Over to you, Dr. Aarti.
Yes, ma'am. Is my screen visible, ma'am?
Yeah. Visible.
Okay. Good evening to one and all present here. Today, I'm Dr. Aarti Rajkumar and I'll be presenting a grand round case. A 34-year-old female anesthetist came with complaints of sudden onset headache since 1 month and a history of tinnitus. There was no history of nausea, vomiting, double vision, or pain on eye movements. She was consulted elsewhere and was diagnosed with bilateral disc edema and was started on Diamox 500 milligrams thrice a day on the advice of a neurologist. In her past history, she has a history of total thyroidectomy done for suspected papillary carcinoma, but the final histopathological report revealed multinodular goiter, and the PET scan showed no nodes. She also has a history of weight gain and was on oral contraceptive pills 3 years ago, but is currently not taking them. On ocular examination, her pupils were around regular reacting to light. There was no REPD. Extraocular movements were full and slit lamp examination was normal. Her visual acuity was 6/5 for distant vision in both eyes, and near vision was N6, and color vision was normal. In the first visit, the fundus photo, which was taken elsewhere, showed bilateral disc edema with a few peripapillary hemorrhages in the right eye, and the Humphrey visual fields done for both eyes showed an enlarged blind spot. The OCT RNFL analysis showed RNFL thickening in both eyes and GCC loss in both eyes. She presented to us again at 1 week and she was on Vicelone, Topiramate, and Diamox. She was advised to continue the oral steroid taper and hike up Diamox to 1 grams per day. PET scan, which was also done, showed no metabolically active disease anywhere in the body, and there was no evidence of neuroparenchymal or leptomeningeal enhancement. A repeat disc photo was taken, showed bilateral disc edema, which was stable in the right eye, but more in the left eye. And repeat visual fields also showed the enlarged blind spot. RNFL and GCC analysis was also repeated, which showed more thickening of the RNFL layer in the left eye compared to the right, and GCC loss in both eyes. At 4 weeks, the patient came with sudden onset worsening of vision in the left eye. She was on Vicelone, Topiramate, and Diamox, and Brevipil. Her left eye vision had dropped from 6/5 to 6/24, and near vision was normal. Her color vision had also dropped to 1/21. There was also a history in reduction of steroid dose, following which the patient was noticed to have a drop in vision. On ocular examination, her pupils, the right eye was normal, the left eye showed a sluggish reaction to light, and RAPD was present. Extraocular movement, there was a slight abduction limitation in the left eye. Fundus photo in the both eyes showed again bilateral disc edema, which was more severe in the left eye, and the Humphrey visual field analysis in the left eye showed constriction of the visual field. At 6 weeks, the patient presented to us, and she had no history of headache or vomiting, and was on treatment with Vicelone and Diamox. There was a further vision drop noted in the left eye for distant vision from 6/24 to 6/60, and near vision drop from N6 to N8. She was planned for a CSF diversion procedure as suggested by a neurologist, and repeat Humphrey visual field analysis showed a further constriction in the visual fields in the left eye. At 7 weeks, she presented to us after undergoing the thecoperitoneal shunt, and following the surgery, patient felt a further vision drop in the left eye. The distant vision visual acuity was still 6/60, but the near vision had further dropped to N36. There was also a significant drop in the color vision in the left eye. Following this, the patient was started on IVMP pulse therapy, and currently she is taking Diamox 500 milligrams twice a day and Vicelone 30 milligrams. The disc photo of both eyes showed bilateral disc edema, and left eye more severe than the right. Investigations done were autoimmune workup, anti-NMO, MOG antibody, serum electrolytes, serum calcium, IgG4 were all normal. CBC, ESR, serum ACE were normal. 24-hour urine calcium was elevated. CSF analysis done initially showed raised glucose and raised protein, and staining was negative. The LP opening pressure was noted to be 205 millimeters of water. A few investigations were repeated, like anti-NMO MOG, which were also negative. Repeat CSF analysis showed elevated glucose and elevated protein. LP opening pressure was again done and was 260 millimeters of water. CSF acid-fast bacillus fungal elements gram stain were negative. Gene expert was also negative. MAN2 was negative. CSF ADA and chlamydia IgM were both negative. MRI brain with whole spine screening was done at the first visit and repeated again at 4 weeks, and no interval change was noted between the MRI scans. So in the flare sequences in coronal and axial sections, hyperintense lesion was noticed in the left paraphylacine cortex. In the T2 weighted axial image, you can see a thickening in the left optic nerve sheath, which is better seen on the fat suppressed MRI scan. The T1 weighted image with contrast in the coronal section shows enhancement of the left optic nerve sheath. Now, further, the patient has been planned for a left eye optic nerve sheath fenestration surgery with a window biopsy of the optic nerve sheath. Just to quickly summarize the case, she's a 34-year-old female anesthetist who came with complaints of headache and tinnitus 2 months ago. She was diagnosed to have bilateral disc edema, left eye worse than the right. All the blood workup was normal. MRI showed altered signal in the left frontal paraphylacine cortex with diffuse leptomeningeal enhancement, and there was also thickening and enhancement of the left optic nerve sheath. She developed worsening of vision in the left eye, the vision dropping from 6.5 to 6/24 to 660 over 6 weeks. The CSF analysis showed increased opening pressure of 260 millimeters of water and elevated glucose and protein levels. She is currently taking tablet Diamox 1 gram and Vicelone 30 milligrams. She underwent a CSF diversion procedure, following which her symptoms of increased ICP have improved, and she is now planned for a left eye optic nerve sheath fenestration with window biopsy. So the provisional diagnosis is possibly an infiltrative lesion, a neurosarcoid, fulminant idiopathic intracranial hypertension, or primary leptomeningeal lymphoma. Thank you.
On to you, Dr. Ambika.
Yeah, actually, this case was referred to us as a neurosarcoid. See, this she's a cardiac anesthetist, by and large. She had classical presentation of a, if you could see in the extraocular motility, she had even an AB deficit of the left eye. So she had all signs of ICP, referred as a neurosarcoid, having an ill-defined lesion in the paraphylacine cortex with a leptomeningeal enhancement. The first LP was not that rewarding, so we repeated the LP. We had a CSF drain. So the LP is showing raised protein, and the leptomeningeal enhancement is unreachable for biopsy. So that is the only reason. And if you could see, Aarti, could you go to that MRI orbit?
Yes, ma'am.
Yeah, so if you could see this optic nerve enhancement and thickening in this fat suppressed images, you see so much of asymmetry between the right and the left eye. And the left eye shows a diffuse enhancement, and it's more like the sheath is engorged with something sitting in the subarachnoid space. So that is the reason why I asked the neurosurgeon whether could you get some cells in the repeated CSF. Are we missing any infiltrative lesion?
1 minute left.
So that is the reason why we wanted to know, should we go ahead and do a sheath fenestration? Maybe we have so many, senior people over here. Could you just also give an opinion on this case? Because we are planning for a sheath fenestration and a window biopsy of the optic nerve sheath of the left eye. So the next take is, do we continue to treat her as a neurosarcoid and escalate the immunosuppression to the next level? Yes, Dr. Murli, or any other takers?
Madam, I think this was the same patient where Dr. Gordon had advised.
Yeah, that's the reason I had brought this
Oh,
entire spectrum what we are going through right now. Because being a cardiac anesthetist, she's quite perplexed, and we are seeing her drop in front of us in 6 weeks. So the next thing is, every time it used to be like one, neuro infection symposium when the patient comes to us. So we used to have so much of discussion whether we escalate the immunosuppression, do we go ahead with a Ritux shot, try for a higher immunosuppression, then why she didn't respond to steroids in the first go? Why she didn't respond to IVMP or an oral taper what we gave? Why her CSF pressure is continuously high? And why should she have an AB deficit? Obviously, there is a probable neuroinflammatory syndrome that is causing a reactive CSF spike, which is causing a atypical IIH-like picture. Rather, I can't call it as an IIH. It might be an atypical papilledema. And that's what is giving a vision problem to her. So other opinions, Dr. Mahesh, Dr. Rohit, or Rashmi?
Yeah, Dr. Ambika, I'm Vivek here. So,
yeah, Dr. Vivek, please.
Yeah, so I was also thinking the way you are thinking like a typical IH, or sometime we do not know. It could be, kind of a different type of papilledema, which we are not able to sort it out. But like if you are planning it for, the like optic nerve fenestration, it would be great to do. I mean, pressure is not that too high to like really a kind of indication for CSF opening pressure, like 260, isn't it? So
yeah, the repeat
it would be always great.
260.
It would be always great to have a B scan and like document that there is a perioptic sheath.
No
fluid.
calcification on CT or
No,
anything.
PET is negative. PET CT
It is-
negative.
So, Dr. Ambika, the fact that it is the
Maybe
sheath is
Jyoti can comment on this. I think Jyoti has treated a couple of patients like this who has been
So it
deteriorated.
doesn't look like an IH or raised intracranial pressure kind of appearance. Even the sheath is too thickened for you to think in terms of that it is an IH or thickened sheath. I mean, I would probably think that instead of just doing an ONSF kind of an approach, you could think in terms of talking to the OP people to go for a, endoscopic, because the biopsy would be required from the sheath should be a little posteriorly, because sometimes you may not get a good piece, or it may not have been, involving the anterior part. So
Actually, we had discussed that with the neurosurgeon itself, because when he was planning for a GA for the shunt, I had asked him, where can we get a combined biopsy of that? See, the sheath, if you could see that it's almost from the mid-orbit to the, like maybe slightly abutting the apex. And it is slightly starting behind the CRA type of origin. The vision is 660 now. So the chances of we having a visual drop in an endoscopic approach, he was not very comfortable because it's too into the orbit level. And transsphenoidal, they had planned to do such biopsy. Even then, like the anesthetist, she herself said that, see, come on, like I'm treating a doctor and I have to be open about that the chances of vision loss is possible. Now, the only question is, are we dealing with a secondary raised CSF spike, or still that it is a neurosarcoid?
I mean, neurosarcoid does look a little less likely based on the, therapeutic response that
Response to
you had.
steroids.
So that looks,
Because sometimes sarcoid can be quite refractile to steroids, where we go for the next levels. But here, she's not behaving like a neurosarcoid. And the amount of ill-defined lesion, what we see in the paracalcine area, that is also not that typical for it. And it's not behaving like a leptomeningeal lymphoma too. So, my
first guess would have always been a meningioma, but
no, it's not a meningioma. We had screened for the CT. We did, in fact, the PET CT too, because we wanted to rule out with a so-called history of thyroid malignancy. Are we missing something? So it is not an MC. Though, in fact, we are hunting that block, what they have reported as MNG. So as of now, please.
as an immediate life, vision procedure, I would think of an optic nerve sheath fenestration with
a biopsy. Because you said the leptomeningeal enhancement is not amenable to biopsy. So otherwise we could have got two pieces.
Exactly.
We need to save her at least her existing vision.
Yeah, it's quite, depressing and she's been working in the same institution where she got the shunt too. So she's so perplexed about losing one eye. And in fact, she's worried about the right eye, which is behaving quite until now. So I don't know when that is going to kick in.
I think we
Thank
should
you.
go on